Thank you for joining us for this episode. Today, we're joined by Philip Cheng, and we're going to be speaking about getting to 1,000 Ortho-K patients and customizing your Ortho-K fits on the Myopia Podcast.
Optometric Insights Media proudly presents the Myopia Podcast, where we give you the latest myopia research, clinical topics, and industry insights. Make sure to subscribe to stay up to date on all of our awesome myopia content. And now to our host, a massive myopia manager himself, Dr. David Kading.
Well, thanks again for joining us for the Myopia Podcast. Today, we're here again with Philip Cheng out of Australia. How are you, my man? Happy Tuesday for you, Monday for me.
That's right. Yeah, another early start, but yeah, it's great having a chat with you. There was such a good talk that we had last time. Had have more things to say.
I know. We scheduled right away because we were enjoying the conversation so much. And why don't, for those people who haven't heard the last podcast, just give us a little quick bio of who you are, where you practice, what you do.
Yep. So yeah, my name is Philip Cheng. So I practice as an independent optometrist in Melbourne, Australia. So I run the myopia clinic here, which specializes in myopia management, ortho-keratology, special contact lenses, and dry eye management. So we see predominantly children here, probably about 80% kids. And it's a growing area of practice, as everyone knows about myopia is a global epidemic, and also dry eye as well is a growing problem around the world.
You know, the good thing about having a pediatric practice versus a geriatric practice is you continue to add new patients. They don't die off as quickly, right? So many of our colleagues who are
it's a big journey for them. Yeah,
it is. It's tough, right? These kids get to spend a lot of time, and then heck, if they become adults, you probably would see them there
exactly.
too.
And then the parents have their own issues as well with their eyes, and end up seeing the whole family. Yeah.
But when you market to kids, you tend to get the whole family. When you market to adults, you may not get everyone. So that's a great marketing strategy. Well, hey, we were going to talk about lenses a little bit more. You know, when it comes to myopia management, we did the numbers, and about 80% of the patients that are treated in my practice do orthokeratology. We don't have spectacles, so that percentage doesn't come into it yet. We hopefully will in 2022 or 23.
Okay.
And intermixed in that 80% is combination treatments with atropine. And then, we do soft lenses or atropine alone for the remainder of the 20%. Do you have any idea, or would you guess what the breakdown is for Ortho-K, spectacles, soft lenses in your practice, even just a guess?
Look, I would say very close. I would say, across the whole spectrum of patients that we see here, probably about 75% will be Ortho-K in terms of their myopia management strategy. And of those 75%, then we're looking at maybe about 40% who are on combination treatments, so with atropine. So those would generally be the high risk kids, the younger kids, or the ones already coming in with high myopia, long axial length, those kind of high risk factors that we treat them aggressively. And I guess in Australia we have spectacle lens options that like the Hoya MyoSmart, which I guess has changed the game a little bit as well, because previously we didn't really have many good spectacle lens options, and most kids would either be on contact lens or atropine. But now with the spectacle lens option, that probably is about maybe 15-20%. So it's a good option to have for the kids who are not quite ready for contact lenses, or the parents are a little bit worried about lenses for them. So it's a sort of like an entry level step towards myopia management. And then I guess the rest of them would be soft lenses.
Yeah.
And then atropine as a monotherapy, I don't tend to use a lot, because if you have a good optical intervention that also corrects the vision and slows progression, why don't we use that first? It makes sense.
Yeah, it does make sense. When you kind of break down here the soft lenses, we were talking offline here that most of those are NatraView or MiSight. Do you think in the last couple of years that number has been increasing or steady?
It's been increasing, I would say. No, one big thing that happened was in the US of the FDA approval of the MiSight lenses. So that's actually even here, parents hear about FDA approval. It's like a seal of approval of this product that's got a good research basis. And obviously they hear from their social media channels, their friends, and there's a growing awareness that soft lens is also a good option. Whereas Ortho-K has been around for a long time, and parents from China, they tend to know about Ortho-K, but not necessarily the soft lens options. So when a child comes in and say minus 0.75, minus 1, sometimes they're not actually the best candidate for Ortho-K because the myopia is actually very low. And as you know, the amount of peripheral defocus that you generate with Ortho-K is dependent on the amount of central correction. So if you have a low myopia case, Ortho-K might not be always to be the most effective option. And I generally recommend a soft lens option for those very low myopia cases.
Okay, so that's kind of how you make that split as to which direction you're going to go.
Yes, well, I guess in terms of prescription suitability, I would say lower prescription, I would tend to use MiSight more, whereas the sort of moderate high myopes, I might use Ortho-K. And also, of course, astigmatism Ortho-K corrects very well. So also, I guess with kids as well, younger kids, parents are more likely to be interested in Ortho-K because they're wearing the lens at night in their home, so they can look after the child more, whereas they can get a little bit more concerned about the kids wearing their soft contact lenses in school during the daytime, all the activities they get up to, swimming and all those kinds of things. So I guess kids who wear soft lenses need to be a little bit more responsible.
Yeah, that's the tricky part is as myopia advances, kids get older too, right? And so as they get older, they may become more mature. Yes. But it's kind of that, if you had a 6-year-old that you were going to be correcting, Ortho-K has some advantages because they're dealt with at home, right?
That's right.
But usually that's when they're in the low myope stage, and that's where that's right. Maybe the soft lens would, presumably, I don't know if we necessarily know exactly that to be the case, but presumably from a refractive component be maybe a nicer option. So that's kind of been the tricky part for me is I want those little kids to deal with Ortho-K so they don't have to deal with lenses at school.
Yeah, look, sometimes I know there's kind of situations like -1, first time myope, age 7, and sometimes the parents don't want the child to wear glasses. Of course, we don't want to undercorrect them or not correct them. So we have to give them an optical option, and they're really, really keen on Ortho-K. So what we generally do would be to start with the Ortho-K. Of course, then if the child progresses more than we like, of course, we add the atropine quite soon after. So they've got a dual combination, a cocktail treatment happening, which I think is quite effective. Yeah.
Yeah. So you also have your fellow in the International Academy of Orthokeratology and Myopia Control, or FIAOMC, right?
Yeah.
Fairly along. Why did you decide to go in become more of a specialist in orthokeratology? Like, what was the stimulus of, hey, I'm going to go for that fellowship?
Look, I think I like to challenge myself. So, I like to do the best that I can for every one of my patients, and that comes with increasing my skill levels. So even from the first time I did Ortho-K, I've always custom designed my lenses. So
really,
So I use a system called iSpace, which is developed in Australia. I'm pretty sure you guys use it in America as well. So customized software designed lenses. So I've got complete control over all the lens parameters, which I really enjoy. Because the treatment zone and all those things will matter in terms of the efficacy. So I don't. I like to be able to customize the lenses for that particular case. So whether it's a high myopia case, adults or children.
Yeah. So because of that, you felt like going through the academy would be a challenge for you, and you would catapult yourself in your learning. Is that?
Yeah, that's right. Yeah, to challenge myself with complex cases and to try to be the best that I can as a practitioner for my patients, because obviously they're coming for this big long journey for myopia management, and I want to be able to offer all the options to them and do the best, give them the best results. So it's also it's not an easy thing to do, even though there's sort of simple ways of going about it, but to get the best results, you need to really invest yourself in the learning of it.
Yeah. what would you say? And I've heard arguments to that, Philip. So that's why I'm gonna push on this just to see your perspective on it.
Yep.
So there are some companies nowadays who they've done studies with their lens designs. For example, there's a study that's on the SMART. It's called the SMART study. And as a recap, there were 10 practices. 8 of them had never fit the lens design before. And it was the Euclid design. And with the first set of lenses, they were about 85% successful getting the patient treated, not on myopia management, from a visual correction to 20/25 or better with the first set of lenses. And then the next set of lenses, if they had to go, got them to 96% if they had to change one lens or another. So I think I agree with you in some ways in that as you get deeper into doing this more and more, you want to have your fingers on it and touch the lens design and adjust things. But is there a place for our colleagues who are not as deep in this as you and I to have something like the new J&J lens or the Euclid lens or the Paragons, where it's fairly simplified? I mean, it's still going to make a difference, but is there a place for those? I just had to push back on you with that.
Look, there is of course a place for those, and it's better to have wider accessibility to Ortho-K than not. So and if there's an easy way of going about it, then of course then that's great. I guess we do sort of have to sort of see the results of these lenses as well. So it's not just about correcting vision, about myopia control. And these lenses is going to be generating as much myopia control benefits as our customer lenses. I guess we don't really have the answer for that right now, but I guess time will tell.
We don't. They didn't finish the complete 3 years in the study, but in the 2 years data that they looked at, they showed over 50% reduction in the progression of myopia compared to a soft spherical counterpart in there. So I think there is some design to it, but could they get from a 50 to a 60 or a 60 to a 70% myopia management? Which would be really interesting to see is if you could, and I don't know, you would do unilateral eye correction. I don't know if we would do that, but a study comparing those of us who do custom designs with either the Wave or the iSpace, or there's several others, versus a Paragon or a Euclid or the J&J lens, the Ability lens. I would be curious to see.
It would be very interesting.
Off the rack. You and I should do that study. We should do that study. Look at it.
That's right.
So interesting. So tell us some of the things that you like to play around with when you're designing a lens. Do you have a preferred OZ or a treatment zone that you're targeting, or what are some things that you go for?
So I like to go for myopia control. I like to go for a small treatment zone. So I like to use a small bag of optic zone diameter. So maybe a 5.2, 5.3, 5.4, because I like to get the amount of peripheral plus within the pupil, or as close to the pupil as we can, because that tends to maximize our treatment results. Of course, it depends on the patient's pupil size, which, also if they're using atropine, it gives us a bit more leeway as well when the pupils are slightly dilated. But of course, it also depends on the refraction. Sometimes you can't use a very small treatment zone for a high myopia case, for example, and you just sort of have to make some compromises.
So when would you go to a 5.2 or a 5.4? What would be some things that would push you to go smaller or bigger?
Sure. So I guess younger kids, we've got a low amount of refractive error where we can use a smaller treatment zone and still get the right amount of central correction. I tend to go a little bit smaller.
What are some of the other changes that you've made recently in your practice that have helped make your myopia management program even better in your practice?
Sure. One of the biggest changes that we made this year was myself delegating some of the roles to our staff members, which has really been, I guess, a game changer for our practice. It's increased our efficiency, our productivity, improved the patient experience as well. So what happens now is that instead of myself doing all the Ortho-K teachers and having done those for the last 4 or 5 years, it's quite repetitive, of course. So now we've got 4 staff members who are taking the role of contact lens tuition for the patients, which is fantastic. These staff members actually handpicked by myself from my own patient list. So they actually experienced Ortho-K wearers themselves. And of course, they know with so much experience in wearing the lenses on a day-to-day basis, they're probably better than me explaining to the patient exactly what to do and dealing with issues or how to do this and little tips and tricks that they have picked up over the years of wearing the lenses themselves. Yeah.
So how old are these employees that you're talking about here?
Sure, it ranges from 15, the youngest one, to I think 20. Yeah, so they're students. Yeah.
And do they just come in and work with you for certain hours of the day, and that's when you do the teaches?
Yep. So we've got there's 4 days in the week, 3 or 4 days in the week where you do Ortho-K teaches and fits. So that tends to be the back end of the week. Yeah. So the students they come in for a few hours at a time. Yeah, and we schedule the appointments according to their schedules. Yeah.
Yeah. Now, these particular 4 employees that you have, they don't make up the bulk of your employees, right? You also have, opticians and
exactly.
people that work the front office and so forth.
Exactly. Yeah.
But it allows you
the roles of these four staff are primarily contact lens assistants, basically. So not just Ortho-K, but of course the soft contact lenses as well. So that's been a really big help. Yeah, we've got a dedicated room where the patients can spend as long as they need to. There's no rush for time as well. So I'm not having to stress in between appointments to try to fit an Ortho-K lens. So they've got all the time to go through it with the staff members who are extremely patient and, being a little bit younger as well, they can relate to the younger patients, really well as well.
Yeah, I love that idea. I think that is a brilliant idea. Are there other things that over the last couple of years you've implemented that has improved things in your practice?
Yeah, we've also invested in a lot more equipment and technology here. So we've got, of course, the new Myopia Master biometer, which we used in the pre-testing phase now with the staff helping out. And we've also got the new Optos, which is really important for myopia management for adult patients, because the high myopes, of course, we need to start screening them for pathology with high myopia. So so we
let's talk a little bit about adults and what kind of conversations you have with adults who are 25 to 30 or even older who are progressing in their myopia, and they say, Philip, what is there anything you can do, and what do you say to them?
Yeah, there's difficult conversations actually, because there's some of them kind of a bit sad. They've come in, they've kind of missed out on this myopia management when they were younger. No one talked about it, wasn't offered, and they've come in minus 6, 7, or 8, and they're now worried about the health of their eyes. Still getting a little bit worse over time. What can we do? Of course, we try to help them, but of course, we also need to be a little bit more cautious about our promises and our what we can expect from our treatments, because as we know that myopia management studies generally don't include adults, right? So 8 to 13-year-olds generally. So we have to extrapolate the data that we know from the kids and try to apply it to adults, which might not necessarily be the case. But of course, it's worth a try. If they're progressing, we can offer Ortho-K lenses, multifocal soft lenses, probably not so much atropine or the glasses. Adults don't really like the atropine too much, dilate the pupils, reduces their accommodation. So, most of them are going to be wearing contact lenses anyway. So Ortho-K is a great option for them. Yeah. The first thing I would say that the Ortho-K lens is going to be for vision correction. So we're going to get rid of your glasses, have the freedom of the Ortho-K lenses. In the daytime, you can see clearly. The myopia control benefits will be more of a bonus. So we still have to measure the axial length because to make sure that if this treatment is actually slowing down any further changes of the eye growth. But I think our expectation is slightly different than the kids.
Yeah. I was just thinking back. There was a study that was published by Kate Gifford, who you know very well. And it was a 12-month Ortho-K study, and they looked at, not older adults, but younger adults, 18 to 30 years. And they found with Ortho-K, they somewhat stabilized the refraction and the axial length. And there was a similar effect showed by another study in 2016. And I think there's still more information that we need to glean from this. Most of our evidence has been around kids, but there just seems to be this, the 22-year-old who now is at university and has first decided to take things seriously, right?
Yes, that's
They're
right.
studying for their first time, and they've gone from a 1 to a 2, right? That's a perfect patient to be like, yeah, let's bring you into it. It's that 50-year-old who's a -7, right? What do we do for you? Ortho-K maybe not as good of an option for them, but what conversations, what kind of conversations do you have with them? Is that a soft multifocal? And
I would say probably
be
more
something
soft
there?
multifocal.
Yeah.
It's sort of that sort of age group. We might be talking about different kind of refractive changes, lenticular changes, for example. Probably not axial length, maybe. Yeah. So there could be other factors that play as well.
And that's the benefit of having an axial length instrument, right?
Exactly.
Still, the value of that machine keeps coming back time and time again.
The high myopes, how good are refractions, the vertex distance, all those things matter when it comes to the refractive component, right? So axial length tells you exactly what's going on in their eye growth.
Yeah. Cool. The last thing I wanted to see how you've changed is in your marketing, right? Mouth to mouth, like word to word, patient to patient is obviously the best way to grow your practice. But are there any external marketing things that you're doing or you've done to try to help spread the word of what you're doing?
Sure. I have to say that this practice doesn't really do a lot of external marketing. The sort of marketing sort of maybe limited to Facebook, Instagram, etc. Because so much of it comes from word of mouth, and it's about patients having the best experience here. And they know that we've had a lot of experience in Ortho-K lenses. We recently fitted 1,000 patients here in the clinic for Ortho-K. So yeah, so it's a big milestone that we've achieved. Yeah, and it's just growing by the week, of course. All the patients basically are like ambassadors for our practice. They go and talk to their friends and their families. There's patients that come from all over Melbourne. Some drive maybe 2 or 3 hours away, come here. So yeah, I think the external marketing side is actually very small here. It's I guess if you focus on doing the best that you can for your patients, you don't need a lot of marketing.
Yeah. What did you do to celebrate 1,000 Ortho-K patients? Was it a yay? Now let's get back to work.
We celebrated that for our staff. Now we made a little image that we've got on our TV screen here. Pictures of little kids. It's quite nice. Yeah,
that is a very cool accomplishment. Now, how long did it take you to get to 1,000?
Well, it took probably about 4 or 5 years, but the growth it's not linear. The first couple of years you have sort of a slow growth, incremental growth, and then the last couple of years with the lockdowns and then also more awareness of myopia management, that's kind of skyrocketed. And I guess that's the thing about myopia management, that everything's sort of like it snowballs over time, right? So and that's the other challenge about managing practice, is that you get more and more patients and they keep coming back, and then you only have a certain amount of time in the day to see them, and all the kids want to come in the afternoons, right? So managing the appointment book becomes a challenge now. Yeah.
What would you say the number of active Ortho-K patients are in your practice? So you fit 1,000. How many would you say are still coming in and year out?
The vast majority, especially the kids, because they come back on every 6 months. They're very good with their follow-ups. Adult patients tend to not come back quite as often, but no, the vast majority, we're still wearing the Ortho-K lenses.
I think that just speaks to the way we go about it. I think that's brilliant. Well, I sure appreciate getting to have another nearly half hour of your time. I appreciate you speaking to us on the Myopia podcast.
Thanks very much for having me again. It's always a great pleasure having a chat here with you. So,
likewise. I learned so much for you. And thank you for joining us for this episode of the Myopia podcast. Make sure to like and subscribe. Stay tuned for future episodes, and we'll see you then.
This podcast was brought to you by Optometric Insights Media. If you enjoy our content, please leave a 5-star review. And don't forget to subscribe for more great episodes.